Hi everyone, my name is Mulawa. I'm excited to have been invited by Jim and the rest of the Social Networks and Health team to present my work to you all. I am an assistant professor of nursing and global health at Duke University, and I've been on faculty for about 3 years. Prior to joining the faculty, I was a postdoctoral fellow at the Duke Global Health Institute for about 3 years, and prior to that, I was doing my PhD in health behavior at UNC's Gillings School of Global Public Health. It's a real treat to share my work with you all. I'm looking forward to having time for questions and answers. As you'll see in this presentation, my research focuses on developing and evaluating social and behavioral interventions for HIV prevention and treatment outcomes. And most of my work has been done in Tanzania, in East Africa, and in South Africa. And I've worked with my colleagues to consider social networks when designing and developing interventions, as well as to use social network analysis methods when evaluating interventions and understanding how they worked, and in analyzing the data that we collected as part of the intervention to understand how networks shape various HIV-related behaviors. I'm first going to show you two applications of social network analysis to an HIV and intimate partner violence prevention study, which I was a part of during my doctoral and postdoctoral training that was conducted in Dar es Salaam, Tanzania, led by Dr. Suzanne Maman at UNC. And then I'm going to share how I'm currently applying social network analysis methods to implement and evaluate an intervention that I am developing to support adolescents living with HIV in their treatment adherence in Cape Town, South Africa. So the first two examples that I'll share are from a study in Tanzania, which was conducted in 4 urban and densely populated wards in Dar es Salaam. This parent study was a cluster randomized trial that was evaluating a multi-level intervention that included 2 main components. The first was a microfinance component. This was a provision of small loans and business entrepreneurship training to young men. We supported this young man here in a tailoring business. We also had a peer health leadership intervention where we recruited men to serve as health leaders and engage them to change norms within their peer groups, all for our HIV, STI, and gender-based violence outcomes. I'm going to talk about 2 research projects that we did within this parent study. And the first is a project in which we looked at the structural network position and the performance of our health leaders within that study. And then I'm going to tell you about a project we did comparing men's perceptions of their best friend's HIV testing behavior with that best friend's actual self-reported HIV testing behavior, to really look at what happens when you compare those perceptions with actual reports of HIV testing behavior. So let's get started. The parent study was, as I mentioned, a cluster randomized trial, and it was called Vijana Vijueni 2. Vijana Vijueni is a Swahili term for youth of the street. The study, led by Suzanne Maman, and examined the effectiveness of this combined microfinance and peer health leadership intervention on HIV, STI, intimate partner violence outcomes among social networks of young men. So this was a cluster randomized trial, and the clusters in the study were peer networks that were locally referred to as camps. Camps are naturally occurring and relatively stable groups of mostly young men. About 80% of members are men, and they have an elected leadership structure like a chairman, secretary, treasurer. Most camps have monthly dues. In this urban setting, most camp members are unemployed, and at least not formally, and they join these camps really to socialize, to support one another, to engage in activities like playing sports or occasionally participating in camp-led business enterprises. Some camps have physical structures where their members gather, and others use public venues like the sides of buildings to establish and demarcate their camps. Suzanne and her team had identified these camps when conducting formative work, trying to find venues to reach young men. They realized that these young men in this target age range weren't in school, but they weren't yet working yet either. And so she did a lot of formative work in which they identified these camps, and the camps have provided a unique way to reach men with intervention programming. So one of the first steps of the parent study was enumerating all of the operational camps within the study area. So this was 4 wards, with wards being similar to U.S. Census tracts. On this map, you can see we had 294 operational camps within the 4 wards of Dar es Salaam. We identified them by conducting structured community informant interviews with community members, and then visiting and mapping all the camp locations. We then assessed camps eligibility and then randomly selected 60 eligible camps for inclusion in our study. We then had our team of research assistants go out to all 60 camps and collect camp rosters, which included the names and contact information for all camp members from all 60 camps. And then we attempted to contact all individual camp members at least 3 times to assess their individual eligibility to be enrolled in our study. So the parent trial, in addition to camp eligibility, had individual level inclusion criteria as well. This included being over 15 years of age, being a member of the camp for over 3 months, visiting the camp more than once per week, and planning to reside in Dar for the next 30 months. Over approximately 1,600, you see here, 1,581 men that were identified on the rosters, we collected baseline data from just under 80% of them. This was quite a big undertaking because there was a lot of individuals across a pretty large area to reach out to, confirm they're eligible, go through an informed consent process, recruit for the study, and then schedule and have time for them to come in and do our assessments. As part of the assessments, our trained interviewers collected behavioral data using tablets that were pre-programmed with a customized designed CAPI instrument, and it showed the camp roster. So this was really important for the network data that we collected and that we were able to analyze. So it showed a camp roster populated for each camp, and participants were asked to identify yes, no, whether they knew the person, and then when they did know them, to say what relationship they had with that person. Was it a friend or an acquaintance or someone they didn't get along with, so negative ties? And then of their friends, if they had at least 3 or more, then they were shown a list of friends, and they were asked to pick their 3 closest friends. If they didn't have at least 3 friends, then they were showed friends and acquaintances and asked to pick their 3 closest friends. This is the consort diagram for the study, and you can see that we assessed about 1,581 men for the trial. Little over 300 were excluded for the reasons you see depicted here, and we enrolled 1,258 men within the 60 camps. They were randomized to receive the intervention or control, and then they received that condition for 2 years. In addition to the baseline assessment, we did a 12-month post-baseline assessment and then a 30-month follow-up as well. And we retained over 80% of men at the 30-month follow-up window. So first I'm going to talk about the project in which we looked at structural network position and the performance of health leaders within our study. This was work that was done in collaboration with Nina Yamanis, Masajo Kajula, Peter Balvance, and Susanna Mann. So we did this study because we knew that engaging network members as peer leaders, sometimes called peer educators or peer change agents, had been a frequently used strategy to prevent HIV when working with social networks. And peer leaders are often trained to model healthy behavior or increase attitudes, shift beliefs, share knowledge, and promote behavior change amongst others within their groups. And engaging peer leaders had been a fruitful HIV prevention approach. There had been meta-analyses that suggested that peer leaders were effective in increasing HIV knowledge and condom use, as well as decreasing syringe sharing among networks of injecting drug users. And peer leaders could be identified in various ways, including self-nomination, nomination by target audience, identification of well-known individuals, selection based on characteristics, or network theory. And the most common way of using network theory to identify peer leaders was by identifying popular individuals or individuals that were nominated by many network members, which is basically the approach that we decided to do, and I'll describe that in more detail. So after recruiting our individuals and having them in the study, we really did this study to dig into the role of structural network position, because existing research was suggesting that the effectiveness of our peer leaders could really depend on the position that they occupy within their social networks. So, for example, there was a study that found that peer leaders who were selected based on popularity were less likely to be innovative when compared to those that were based on being in a high bridging position, a position that was more characterized by connecting otherwise minimally connected subgroups. And this was because popular individuals, those with a high in-degree centrality, so as you can see, Jill in the sociogram depicted here is the center of a group, high in-degree centrality, highly popular. Those individuals might feel more pressured to support prevailing norms, to be able to maintain this prominent position within their network. And individuals who occupy positions between subgroups of otherwise minimally connected groups tend to have fewer friends in the network, and as a result might feel less pressure to support those prevailing norms and subsequently feel more freedom to innovate. So health leaders in the Vijana Viju 22 study were identified in 30 of the 60 networks. They were identified through peer nomination. So we did not use the sociocentric data that I described with the tablet. That was part of the baseline assessment, and we did not use those data to identify our peer leaders. Rather, we had group discussions within each of the 30 intervention camps where we talked about characteristics of leaders. What does it mean to be a good leader? What characteristics should they have? And then after that group discussion, we had camp members each nominate up to 3 camp members who might fit that description. We then invited those with the greatest number of nominations, and we sought to engage about 20% of members in each camp. So using that 20% as a benchmark, we had about 180 eligible individuals that were nominated. And 170 of them ended up completing the camp health leader training, which was really high. We realized this was likely because the training was paid. They were, like I said, largely not formally employed, so they had the time. They were really interested in being involved. We had really high levels of participation. 90% of those completed the 12-month assessments, and we're going to be pulling from those data for this analysis. So you can see here that even though we used an approach that was designed to identify some of the popular individuals, we didn't use our sociocentric data to identify them. And when we looked at them, we realized there was actually quite a wide range in their network position. And so we felt like we had an approach to be able to contribute to this question about how network position shapes performance of peer leaders. So our purpose was to describe the structural network position of our health leaders and to examine that association between that position at baseline and the peer leader's self-reported performance at our 12-month assessment. And the outcomes that were available to us were their confidence in educating other network members about HIV and gender-based violence. These were questions that were asked of each of the peer leaders on a 4-point Likert scale. And then the peer leaders were also asked to report the number of past week conversations that they had about those 2 topics as well, separately. And our hypothesis was that those with a higher in-degree centrality or higher popularity might have a lower confidence and a lower number of conversations because of that pressure to conform with norms. And those with that higher betweenness centrality might have a higher confidence and a higher number of conversations about both HIV and gender-based violence because of this, more freedom to innovate and to go beyond what the network is doing as a whole. So we analyzed data among our 153 health leaders who participated in the 12-month assessment, answering questions about their performance. And we computed measures of in-degree centrality and betweenness centrality for each. You can see here I've depicted one of our sociograms for one of our 30 intervention camp networks. And the darker gray nodes are our health leaders. And you can see I've identified peer leader A that has a relatively higher in-degree centrality and peer leader B that has a relatively higher betweenness centrality. There was a wide range in network structures, and as I mentioned, we had a wide range in these network positions as well. We then fit models using generalized estimating equations with standardized predictors and controlled for individual and camp level covariates. The characteristics of our 153 health leaders are presented here. The vast majority, 85.8%, of the health leaders were men. The mean age was 26.3 years. The majority had primary school education or less. Most health leaders, 70.6%, had never been married. The average level of confidence across all peer leaders was a 3.4 out of a 4, or on a range of 1 to 4, with a standard deviation of 1, regarding their confidence in educating peers about HIV, 3.4 in their confidence regarding HIV and their peers about gender-based violence, and the average number of past week conversations in the scale on the previous slide was 1.7 for HIV, 1.5 for gender-based violence. Now, when we looked at confidence as our outcome and the health leaders' confidence in educating their peers about HIV, or their confidence in educating their peers about gender-based violence, and looked at predictors of that, we found that there was actually no significant association between increasing levels of in-degree centrality and self-reported confidence in engaging peers about HIV or gender-based violence, though we did note that the direction of both of those relationships was positive. And similarly, there was not a significant relationship between the centrality and confidence in engaging peers about these two topics, though the direction of that relationship was negative, which we did consider. Then we looked at the actual reported number of conversations for each of these topics, for HIV and for gender-based violence, for our health leaders, and looked at predictors of that. And as we can see in this table, an increasing level of in-degree centrality was associated with fewer numbers of conversations about HIV after controlling for our individual level covariates and network level covariates as well. And increasing levels of in-degree centrality was marginally associated, it was a p equals 0.06, with fewer numbers of conversations about GBV, but mostly that trend was also negative. Increasing between the centrality, so that bridging position, was actually significantly associated with increased numbers of conversations about gender-based violence. And the relationship between increasing levels of between the centrality and conversations about HIV was also positive, but it wasn't statistically significant. So what did we learn? As the in-degree centrality of our health leaders increased, they tended to report fewer conversations about HIV-related topics. And even though this was consistent with our hypothesis after having looked at the research on this, we were still surprised. And I think that's because our health leaders who were more popular had more friends. They had more friends, they had more close friends, they were more likely to be identified as a close friend of others, and still yet they had fewer conversations about this topic that they were enthusiastic to come to the training for. So our findings here were supportive of this notion that peer leaders that are central might be more reluctant to engage in conversations about sensitive topics or engaging in sensitive activities like talking to their friends about ways to prevent HIV or gender-based violence. This might be because they have that pressure to conform with norms, or because they don't have time to engage in these types of activities. They've got their popularity burdens them with other activities that they need to do to maintain this position. And so they have less freedom to, spend time thinking of ways to do this other activity. As between us centrality increased, on the other hand, our health leaders did report more conversations about gender-based violence. And this supports that notion that those individuals in that bridging position, those that have these more gatekeeping positions, that have fewer direct friends themselves, may have less pressure to behave in ways that support those prevailing norms and may feel more comfortable. And because of this reduced pressure, they might be more willing to, raise topics that go against what the norm is. They also likely have fewer friendships to maintain, which could also give them more time. And they might be able to devote more energy to thinking strategically about how to best engage their peers in these conversations, how to start them, how to maintain them, how to return to them over time. We need more work to understand the mechanisms of these relationships, but we thought it was interesting that they were consistent with our hypotheses and what others had found in the literature. When looking at confidence, the story was more complex. While the findings were not significant, they were in the opposite direction. So our peer leaders who were, had increasing levels of popularity and in-degree centrality, while they were reporting fewer conversations, the trend for their confidence was actually greater. And individuals that had increasing levels of that between a centrality, while they were reporting increased conversations, their confidence, though not statistically significant, was negative or in a different direction, at least the trend. And so this could be because occupying different positions within networks is associated with other personality traits and might include confidence or lack thereof. What we took away from these findings were that strategically in recruiting individuals that have greater betweenness centrality might be a way to maximize interventions that use peer leaders, and that boosting confidence and having part of the training be approaches to try to boost confidence might also be important as well. I'm now going to shift to the other project that we did, comparing perceptions with actual reports of a close friend's HIV testing behavior. This was also work that we did in collaboration with Nina Yamanis, Peter Balavans, Musajo Kajula, and Suzanne Maman. So just as context for those that might not be too familiar with this, men in sub-Saharan Africa really experience higher rates of AIDS-related mortality compared to women. And this is thought to be a combined result of their low testing rates, their delayed treatment, then into initiation, as well as poor treatment adherence, on and on in the cascade. HIV testing serves as this gateway into the treatment and care continuum for those who test positive, but it's also for those who test negative an important way to enter prevention intervention as well, including pre-exposure prophylaxis for those who test negative but are at high risk. So given their increased risk for AIDS-related mortality and this important role of testing, there's been several calls to increase men's testing in this region and to understand barriers and approaches and facilitators and what we can do. So one promising approach could be leveraging peer testing norms. And we have data that peers play an important role in shaping young men's health behaviors, including their decisions to test for HIV, and know that HIV testing behaviors tend to cluster together in peer networks, including in our own. And so we thought that we had a unique opportunity here to look at how perceptions and misperceptions of norms, of friends, could help inform future intervention approaches. So the purpose of our study was to compare men's perceptions of their closest friends' HIV testing behavior with their friends' actual testing self-report. Because remember, we tried to enroll the entire camp networks as much as possible, fully sociocentric. And so when men identified a best friend, usually we had that best friend enrolled in the study as well. So we could look at the accuracy, how often they were right versus wrong, and the bias when they're wrong, in what direction do they tend to be wrong of these perceptions. And then we thought it would be really quite interesting to look at that accuracy and bias when comparing men who have not tested for HIV before to those who have tested for HIV before, to see is there a difference there and what can we learn from it. So we analyzed data from 823 men for whom we had complete data on their perceptions of their closest friends' HIV testing behavior, as well as their closest friends' actual self-reported HIV testing behavior, and the participants' own HIV testing status. So we compared their HIV testing behavior of the closest friend to the perceptions of the individual to see if we could categorize each participant into one of these buckets. So the first being that they correctly rejected HIV testing in their friend. So when asked, did your best friend, do you think they've tested for HIV? The participants say no. And then when you ask the actual best friend in another, interview the next week, have you ever tested for HIV? They say no. So there's a match, there's a correct rejection. Or whether they falsely rejected. Whether you ask them and they say no, and then when you ask the friend says, no, I have. Yep, I've tested. Or whether they falsely identified. Whether in case saying, yes, I think my friend has tested, turns out the friend hasn't, or correctly identifying HIV testing. So there's a concordance there on perceiving yes, and that being accurately reported by the peer as being yes, indeed, they have tested. We then calculated non-parametric measures of accuracy and bias of perceptions, and they range from 0 for accuracy to 1. So 0 was completely inaccurate. Everyone was totally wrong. They, were in whatever direction. They said their friend had tested when they hadn't, or they said they hadn't when they had, or to completely accurate, either correct rejections or correct confirmations. Bias, on the other hand, ranged from a -1 to a 1. So -1 was a complete liberal bias, meaning participants perceived HIV testing regardless of its presence. So when they were wrong, they were always saying that their best friend had tested for HIV. A 1 was a complete conservative bias, meaning that they were not perceiving HIV testing, even when it was present. So when they were wrong, they were always saying that HIV testing did not happen. Their best friend had not tested for HIV. Okay. Then we looked at how accuracy and bias differed amongst the men who had previously tested themselves compared to those who had not tested before. So when we look at the accuracy and bias rates for non-testers and prior testers, we see that accuracy was actually not that different. In the table below, you see that the accuracy for non-testers was 0.58, accuracy for prior testers was 0.6. So they were not very different in their accuracy of knowing whether their best friend, had tested for HIV, which told us something. It told us that, there's room there to increase that alignment, but there was not a real difference in terms of non-testers and testers. What was interesting, though, is that there was a low correct identification rate and a high false rejection rate amongst non-testers. Okay, so what this means is that non-testers themselves were, when they had a close friend who had actually tested for HIV, only about a quarter of them accurately perceived testing in that closest friend. Okay, that correct identification rate was only 0.26. The vast majority of non-testers, they falsely rejected testing in their closest friend when it had actually occurred. So the false rejection rate was 0.74. Okay. Non-testers were strongly biased to not perceiving HIV testing in their closest friends, while testers didn't really have, it was really close to 0.06. They only had a slight bias in that same direction, but really it was they were just as likely to say they had tested when they hadn't, or they hadn't when they had. So what were the implications of this study? Well, we learned that men who hadn't tested for HIV were biased in their misperceptions of their closest friends' testing behavior, tending to assume that their friends had not tested before. And we continue to see this as an opportunity to increase men's uptake of HIV testing, and by engaging in interventions that support social norms approaches designed to correct bias misperceptions by revealing the true extent to which those close friends are actually testing, to shifting these norms by getting folks to talk about their testing experiences with their closest friends, and hopefully using that as an opportunity to shift the narrative of what men in these settings, think others like them should and are doing. So I'm now going to shift to talking a little bit about a research study that I'm doing in collaboration with colleagues at the University of Cape Town in South Africa and collaborators at the University of North Carolina at Chapel Hill, as well as others here at Duke that are supporting this effort. Today I'll be telling you how our team has developed, beta tested, and will soon be pilot testing an intervention called Mossy, which is to support antiretroviral therapy, or ART, adherence for adolescents living with HIV in Cape Town, South Africa. So as a background here, interventions to improve adherence to ART are really urgently needed for adolescents living with HIV. There's approximately 1.8 million adolescents that are currently living with HIV worldwide. There's also millions of children that are living with HIV that will be growing into adolescence in the coming years. And this is a really important population to target because Adolescents repeatedly demonstrate lower or suboptimal adherence to treatment compared to adults. And this is associated with increased morbidity and mortality. And adolescents are the only age group that's not seeing those declines in AIDS-related deaths, or not seeing the benefits of treatment because of these adherence challenges. And AIDS actually remains the leading cause of death among adolescents in Southern Africa, where this research is based. Barriers to ART adherence amongst adolescents are multifaceted, and they include factors at the patient characteristic and experience level, so things like mental health challenges, not knowing their status, perceived stigma, perceived lack of social support, experiencing social isolation, as well as patient experiences forgetting being away from home or experiencing disruptions to their daily routines. It can also be caregiver-related characteristics, including the level of support that their caregivers provide to adolescents, medication-related factors like pill burden and palatability, and environmental and healthcare-related factors, including long distances to health facilities and services not being youth-friendly or with hours that conflict with school. Digital health interventions have a lot of promise as an effective way to improve ART adherence. Access to mobile technology is rapidly increasing amongst youth in South Africa, that is elsewhere. And using smartphone apps to support adolescents and engage their social networks may be a way to improve their adherence to treatment. This is critical for all folks living with chronic illnesses, but adolescents are particularly sensitive to social influence. And we're learning more and more about social brain development and their developmental period, which might result in a heightened responsiveness to contextual influences and greater distress due to social isolation and exclusion. Social networks shape behavior through influence and comparison, social support and engagement, and many of these can be leveraged in app-delivered interventions. Our team developed Mossy, which is a COSA acronym that stands for Let's Empower Each Other and Improve Our Health, a smartphone app-based intervention delivered both through Android and iOS to support adolescents living with HIV in Cape Town. Mossy was built using the Health Empowerment Platform, which was originally developed by Dr. Lisa Heitha-Weidman at UNC. The latest version of Health Empowerment, or HMP, is currently being implemented and evaluated to see if it can help address intersectional stigma among Black and Latinx men who have sex with men and trans women in a nationwide randomized controlled trial in the US that launched in July of 2020. And I just want to show you a little bit about what Mossy includes, some of the features. Many of these are the similar features as the HMP platform. Some have been expanded. So Mossy includes tools for self-monitoring and habit formation. We have a health tracker where you can set up tailored reminders for when you want to get notified to take your medications with customized prompts that you can then edit. There are ways to track your adherence and then visualize your analytics, as well as tracking other related behaviors as well. We have many informational pieces, including an Ask the Expert feature where participants can submit questions to our expert, which is our COI, or site COI in Cape Town, Dr. Jackie Hoare, and she answers them, provides the answers to the questions that they ask. There's also many activities, including resources for goal setting and action planning, where participants can pick a goal, get tailored feedback depending on what they want to work on next. There's also quizzes, self-assessments, sorting activities, many different types of engaging activities to try to get them to engage with relevant content. Notably, Health Empowerment and Mossy are very comprehensive. So adolescents tell us all the time they don't just want an app about HIV. They have many other issues and concerns and worries, and we do our best to be responsive to those and create content that meets their needs. Most importantly is our forum. And so this is where our participants have the opportunity to interact with each other and to interact with our peer mentors. Peer mentors are adolescents that are also living with HIV, but they tend to be a little bit older, and they're really thriving. They're doing well. They're engaged in care. They may have experienced challenges in the past, so they can reflect on them, but they're doing well now. They like to facilitate in-person support groups, and they like to facilitate these online asynchronous discussions as well. So our forum is designed to be able to enable participants to post pictures, videos, GIFs, just text posts, to be able to comment and reply, to like, to follow, and to really foster connection between our users and our peer mentors. On the back end, we also want to make sure that we can extract all the data for all those interactions as well, so we can understand how interaction and engagement in the forum is occurring. So we completed beta testing between August and December of last year. We had 12 participants enroll in a 3-week beta testing period. We conducted semi-structured in-depth interviews before the app testing phase, and then let them use Mossy for 3 weeks. After 1 or 2 weeks of that, we did a follow-up interview. We extracted our data from a Mossy SQL relational database to look at user engagement during this phase, used that data to kind of think of what prompts we wanted to ask our participants at their follow-up interview so that they could be informed by their actual use of the app, which was great because it gave us an opportunity to really dig into some interesting patterns that we found. In general, our beta testing experience supported the feasibility of using Mossy and participant devices. There were no major technical issues. Participants logged on an average of 28 times and spent an average of 52 minutes on the platform. They spent the most time using the health tracker and then reading resources and then engaging in the forum. We learned that participants who prioritize resources and activities told us that they liked it because it helped to keep their minds busy instead of wandering. Some linked it to improving mental health because they didn't have to just stress about their own problems, but they could be doing something active and felt like they were learning, which was surprising. Those that use the health tracker to track adherence tended to also track meals and mood. Those that had, many of our participants actually had really high expectations for the forum, and they tended to go to it a lot, but there wasn't a lot of very active engagement in the forum. They read, they scrolled, we could see that they were clicking and viewing, but they weren't as active in it. So we're doing a lot to prepare for next steps to make sure there's lots of content there if they just want to read, and also thinking of ways to increase the likelihood that they might comment or have an opportunity to provide a perspective or answer a question in a poll and see the responses of their peers. And importantly, the beta testing was also a period for us to make sure that we could extract the data that we needed to from the back end to be able to visualize what's happening from a network perspective in the forum in the actual pilot RCT. So here you see a network diagram depicting a bipartite network of users and forum posts. So the users are in circles, and you can see that we had different types of users. So our admin, me, and Mulawa, our research manager in Cape Town, are in green. Our 2 peer mentors are in purple. And then we had 8 in yellow participants who actively either created a post or commented on a post or replied to a post. All depicted here. The orange or salmon-colored squares are each of the unique posts that were made in the forum. And the edges represent the existence of either the creation of that post or a comment or reply to that post, with the thickness of the edge also representing the number of posts or comments or replies made to each post. So not too many lessons learned from this analysis beyond maybe the centrality and importance of peer mentors in facilitating our conversations, as well as active admins. But we really hope to be able to use this information over time to be able to learn more about engagement within our platform once we're in the pilot. So this might be looking at, what are the characteristics associated with the forum posts that did spur active engagement. So were they more likely to be written by a peer mentor or an admin or a participant? Or were they posts that had a poll? to be answered, or were they posts that had an image or a GIF or a video or just text polls? Were there specific content about it that was more likely to generate a response? And then also looking at whether those that become more central in their forum networks have better outcomes or different outcomes over time, and being able to model those as well. For our next steps, we're going to be doing a pilot randomized controlled trial with 50 participants to look at the feasibility, acceptability, and preliminary efficacy of Mossy on self-reported adherence to treatment and social support. Our participants will be randomized 1-to-1 to either the intervention, Mossy, or an information-only version of it that will only have our resources, but none of the other features. We'll have assessments at baseline, 3 months, and 6 months, and then we're really hoping to seek additional funding to support some of the other analyses that we want to do to increase our understanding of engagement, especially in the forum within Mossy. So I have enjoyed sharing this update with you all. I look forward to our discussions. Feel free to reach out to me by email if you have any questions, or if I could provide any other information about this presentation. Many thanks. Take care, everyone.